Thank you very much, Jeremy, for that very kind introduction. Good afternoon, everyone, and this is just the last session. I hope you enjoy it as you have enjoyed the rest of the symposium. So I'm going to talk about why empathy in healthcare in Indian context and also South Asia, where we are working on a few grants to be able to draw parallels between scenario in India and some of the South Asian countries. So as Jeremy introduced me, I work on non-communicable diseases. And when we pick up figures like these, two very important figures I want to highlight here is I work on diabetes, hypertension, and obesity, all the NCD risk factors. So empathic interaction with doctors improve diabetic patients' glucose control and result in 42% fewer emergency department visits. So definitely, if we have data like this, it is very, very important that we focus on empathy. And another important condition for chronic conditions is drug adherence, treatment adherence, which again can be improved with empathic health systems. So there are barriers to empathic care in low and middle income countries. Definitely the high patient load that I have been talking about in the last 2 days, doctor to population ratio, nurse to population ratio, but also lack of structural interventions. We do treat conditions but fail to address the social determinants that are influencing and exacerbating the chronic diseases among people in our communities. Empathy does exist in many guidelines, whether it is medical curriculum, nursing curriculum, but in practice, there is no opportunity to implement what has been learned. So something which has not been practiced is forgotten as the students become professional doctors, junior residents to senior residents and consultants. They forget this skill. So Hriday is a non-government research organization. We work on non-communicable diseases and also host the secretariat of the Healthy India Alliance, which is the India NCD Alliance, a consortium of 39 member organizations. So these organizations are working on diabetes, cancer, respiratory disease, cardiovascular diseases, obesity. So they have their silos, but we bring all of them together to be able to understand that the WHO framework of non-communicable diseases has this 5x5 framework that all these chronic conditions have common risk factors of unhealthy diet, physical activity, tobacco, alcohol, air pollution. So working on these determinants, but again, health system strengthening is an important component which we focus on from the community perspective as well as from the health system's perspective. Also moving on, we have been seeing that it does require a policy push to be able to have empathic health system. And for that, we started with India advocacy agenda of people living with non-communicable diseases. This is an extension of what Global NCD Alliance started with doing community conversation of people with lived experience, asking as to what are the challenges they faced while they were navigating the health system. And the solutions they propose help in strengthening the policies and programs. So this India advocacy agenda brought out important facts like health rights, respect, equity. These were some of the identified gaps in the health system. Also, patients did bring up that they had to be included on the decision-making tables when programs or policies are being developed for them, because they know where the barriers are, where the roadblocks are, and they have navigated that health system. So with that, we built a communication and advocacy training manual for Southeast Asia region, where people with lived experience from 9 different countries were trained to become community leaders, to be able to get more patients engaged to voice their opinions. Subsequently, we have been working with the state governments on ensuring that health system responds to these patient voices. Also, we have brought the issue of meaningful engagement of people living with NCDs in the G20 summits. So all the opportunities we got at the national level, subnational level, regional and global level, we have ensured that meaningful engagement is advocated, which means not a tokenistic tick on the checklist that a patient has been included in a committee, but getting them more meaningfully involved so that they can inform the programs and policies. As a result, in 2023, when our national program on NCD was being revised, we actually got the terms which we advocated for in the policy document. The meaningful engagement of people living with NCDs became a part of our government document. Also, the India advocacy agenda did find a place, and it was proposed that these functions will be operated by patient community-led groups. Now, when this came in the policy, we needed some models. So we applied for an NIHR grant with various partners in India and Nepal, and we were able to get NIHR GHRC grant for multiple long-term conditions, which is a term which means NCDs happen in clusters in an individual. Somebody with hypertension may also have diabetes. Somebody with cancer may have mental health conditions. So treating them in those clusters. So this center has a larger vision of system transformation to improve care for people living with multiple long-term conditions in India and Nepal. And the community engagement and involvement is a mandatory requirement of this center grant, which is participatory, meaningful engagement of lived experience and communities. Also, training the people in the community to become community champions. So they are becoming a bridge between the health system and the community. And supporting research and providing this gap to be reduced. Also, when we spoke to the people with lived condition while we were writing this grant, they completely agreed that yes, you can train us to become community champions. Would the health system embrace us? We are trained, but if the health system doesn't embrace us, then what is the whole point? And we introduced the component of engaging health system to leverage the value of CEI, that is community engagement and involvement, to provide an enabling and equitable environment. So with that, our pillars for community engagement and involvement are, we start with identifying people with lived experience, engage them to co-create intervention with us, understand and gain insights from them to be able to design effective interventions. So solutions are also jointly designed with the community. We build their capacities from the point of view of driving change, how they can be effective agents of change in the community, and develop lived experience support networks. So each community champion has a patient network of 10 patients under them who they ensure they connect to the health system for early screening, early diagnosis, and treatment adherence. This is also well aligned with what WHO released as the WHO framework for meaningful engagement, and also the NIHR community engagement and involvement principles. So we use all of them. We started with involving the community at the earliest stage. Even when we were writing the application, we took into account their concerns and views. As we started the grant, we conducted several community conversations and in-depth interviews with different stakeholders. As I've also mentioned, that there are multiple challenges when we are talking to patients, and I will show you the context that I am talking about. But they still, with that limited resources and all the constraints and barriers, gave us strategies like establishment of community advisory boards, which are with the healthcare providers but also with the patients, who jointly identify what are the problems at the primary healthcare center level and they try to find solutions together. They felt health awareness is missing in the community, so for behavior change, it is very important to regularly engage community in awareness campaigns. Intervention briefs are where community champions and the healthcare providers are highlighted, their achievements, how they have reached out to the community. They are recognized and acknowledged. So this becomes a big incentive, and every time we talk about community engagement, incentivization becomes an important piece. And hearing from the patients themselves, so micro-documentaries and visual storytelling. I will pause here and show you a glimpse of what is the community we are working with.
गाउँघरमा जाने अलिकति गाउँघरको समाजमा चाहिँ त्यस्तो खालको कमी छ कुरा बुझ्नुहुन्न र रोग लागिसकेपछि आत्तिनुहुन्छ अब के गर्ने भन्नुहुन्छ
బీపీ వచ్చిందో తెలియగానే భయపడ్డాను. నా చిన్న వయసే కదా అప్పుడే బీపీ వచ్చిందంటే నేను అనుకున్నాను అనమాట.
तो बीपी शुगर का ध्यान नहीं हो कि बीपी का ही हो गया शुगर का ही हो गया। तो एक दिन अचानक मैं सुबह सुबह पानी सी चली थी और दिमाग बैठा तो मैंने चक्कर आ गया। चक्कर आने के बाद में मैं नीचे गिरी तो बच्चा को जो हॉस्पिटल ले गया। हॉस्पिटल ले गया वो तो चेक करिए जब पता चल गया क्या कह दीजिए बीपी और शुगर है।
నాకు 32 సంవత్సరాలు ఉంటాయి. 32 సంవత్సరాలు ఆ వయసు ఉంటుంది. తర్వాత ఆ 2 సంవత్సరాల తర్వాత మళ్ళీ కిడ్నీ కూడా ప్రాబ్లం అయిందన్నమాట.
2020లోని మా ఫ్రెండ్ హోమియోపతి డాక్టర్ దగ్గరికి నేను వెళ్తే జనరల్గా చెకప్కి వెళ్తే బీపీ చూశారండి. చూస్తే నాకు 160/100 ఉందని చెప్పేసి అని నాకు తెలిసిన మరుక్షణం మా అమ్మకి మా మిస్సెస్కి కూడా చెప్పడం జరిగిందండి. దానివల్ల వాళ్ళకి ఇంత త్వరగా బీపీ వచ్చిందని చెప్తే కొంచెం నిరాశ చెందారు.
मलाई प्रेसर चाहिँ मलाई थाहा भएको चाहिँ म 2039 सालमा म आर्मीमा जागिर नोकरी गर्थेँ र शान्ति सेना जानलाई चाहिँ मलाई सिलेक्ट भएँ म। त्यसमा चाहिँ प्रेसर जाँदाखेरि मलाई प्रेसर देखा परेको हो। अब 2048 सालसम्म मैले कुनै औषधि सेवन गरिनँ।
मलाई चाहिँ सुगर भयो 2016बाट थाहा भयो। मैले थाहा पाएर पनि मैले चाहिँ औषधि चलाएँ त्यो बेला, किनभने म त कन्ट्रोल गर्न सक्छु कि भनेर मैले औषधि लिएँ। अनि त्यसपछि हस्बेन्डले यसरी तिमीले हुँदैन अब औषध खानुपर्छ भन्नुभयो उहाँले। त्यसपछि मैले 2018बाट चाहिँ मैले डक्टरको परामर्श अनुसार चाहिँ मैले औषधि सुरु गरेँ।
तो ऐसी सिचुएशन, ऐसी कंडीशन को जिसमें कि एक बीमारी के साथ 2 या 3 बीमारी हो तो इसको हम लोग मल्टी मॉर्बिडिटी बोलते हैं, या इसको मल्टीपल लॉन्ग टर्म कंडीशन एक नया इसका शब्द इस्तेमाल किया जाता है। इसमें अगर किसी को कैंसर है तो उसको मानसिक परेशानी भी होगी और उसके हार्ट के और किडनी का भी परेशानी हो सकती है। तो ये कंडीशंस एमएलटीसी कहलाती है।
हाम्रो यो वडामा समस्या भनेको चाहिँ औषधि राम्रोसँग वितरण भइरहेको छ। पहिला 1-2 महिना राम्रोसँग भयो, अहिले भइरहेको छैन। अनि दोस्रो अब बिमाको निरन्तर रूपमा कामहरू भइरहेको छैन। अनि तेस्रो चाहिँ अब हाम्रो यो लुनीमा केन्द्र स्वास्थ्य सहरी केन्द्रमा चाहिँ पहिलादेखि नै हाम्रो ल्याब टेस्टहरू थियो, तर अहिले पनि सबै चाहिँ फ्रीमा छन्, एउटा दुईवटा मात्रै फ्रीमा छन्।
గవర్నమెంట్ సెంటర్లో ఉన్న మెడిసిన్ ఒకే మెడిసిన్ దొరకడం వల్ల నాకు రాసే ప్రైవేట్ డాక్టర్లు కాంబినేషన్ మెడిసిన్ రాయడం వల్ల దొరకలేదని చెప్పేసి ప్రైవేట్కి
अब समाजमा विभिन्न रोगहरू लागेका मान्छेहरू फेला पर्छन् आफ्नो रोग अनुसारको अर्को परिवारले राम्रोसँग त्यसलाई चाहिँ नि देखरेख गरेर बेलामा डक्टरको चेकअप गरायो भने सबैको त्यो सल्भ हुन्छ
అంటే పల్లెటూరులో అయితే పెద్ద పెద్ద డాక్టర్లు ఉండరు ఇలాంటివి కొంచెం చూడడానికి అది మామూలుగా అయితే బాగానే చేస్తున్నారు ఆశా వర్కర్లు వీళ్ళందరూ కూడా బాగా చూస్తున్నారండి హాస్పిటల్కి వెళ్ళినా కూడా పట్టించుకుంటారు కాబట్టి మంచి పల్లెటూరు కాబట్టి ఇక్కడ పెద్ద డాక్టర్లు ఉండరు కాబట్టి సరిగ్గా చూడలేదు.
So I wanted to give you a glimpse of what we are dealing with. It's not just the health system, but there is access issues, there are awareness issues, there are myths related to health conditions, there are traditional healers people go to before they come to the health system, which delays proper treatment. So with those multitude of issues, community engagement becomes very important. So all the barriers that we captured have just been released today in BMJ Global Health. This is our first publication where you can very clearly see in the themes lack of empathic care comes out as one of the important findings. And the solution which has been proposed is train healthcare providers in empathy, listening and non-verbal cues. Very important that community was able to identify that the doctor's body language or frontline health workers' body language and the way they would welcome them into the PHC is so very important. With that, another recent report that we have come out is looking at non-communicable diseases from the equity lens. We applied this to strengthen the agenda of NCD prevention and control in India in 2 cities, Delhi and Hyderabad in down south, ensuring equitable access to care and reducing health disparities across diverse population. And when we mapped out the barriers and solutions, we do see inadequate human resources, financial burden, unavailability of medicines as very prominent barriers. But in the strategies or the solutions, community engagement and empathic approach comes out very strongly as a solution or a demand from the community. So with that background and very much motivated and inspired by the Stonygate Center, we established Center for Empathic Healthcare in India at Hriday, with a vision to be able to establish equitable healthcare systems and having a mission to transform patient care through not only education but also adopting the 3-pronged approach of working with the community, community empowerment, working with the health system on capacity building, and working on programs and policy to be able to have endorsement and accreditation to empathy as an important skill and ranking criteria. So our objectives are identifying gaps, establishing the center, which we have done. We are now developing training modules, and promote research is a very important component, because if it is not evidence-based, we will not be able to bring about program and policy changes. These are our activities that are being undertaken. And most important is the community engagement part, and we are also looking at digital initiatives. This is how we co-created the Community Champions and Health Professionals courses. It has a module on empathy apart from other detailed modules, but we do have a committee, and in every committee, patient representation is mandatory. Our module is 10 to 12 hours course duration, delivered over 2 days with 5 to 6 hours of sessions. And we pilot tested our first training course with Trained Nurses Association of India, their Delhi chapter, and got very encouraging feedback, because nurses felt, yes, they have been trained into it, but have forgotten those skills because they are so busy, but it's always good to have somebody reminding them of these skills. Recently, the National Medical Council announced a public request that stakeholders who wanted to contribute on accreditation and ranking framework for medical colleges should send in their recommendations. And we did send recommendation on community engagement, patient engagement, and empathy to be included. We will keep you informed if we are successful or not in achieving that. As I said, evidence generation is a priority for us, so a scoping review is being completed at the center to be able to collate all the evidence from low and middle income country context. And with that, I would like to acknowledge Jeremy for inspiring us to start this initiative in India, and NIHR for helping us establish this center, which allows us to pilot trainings as well as test a few models on empathy and healthcare. Thank you.